안녕하십니까, 김경원입니다.
Hello, this is Dr. Kim Kyung-won. It's a pleasure to connect with you all again through this online surgery. Let's begin by looking at today's case. We have a 63-year-old male patient. His main complaint is discomfort in the lower anterior region with the gums receding significantly and occasional mild discomfort. He didn't report severe pain but expressed concern over the receding gums and unsatisfactory feeling. Additionally, he mentioned that tooth number 45, where he previously had a crown placed, was fractured. As mentioned, the patient complained of crown fracture in tooth number 45 and discomfort in lower anterior. The surgical plan is to extract the 4 remaining teeth between the canines and the lower anterior and place immediate implants. The plan was to extract the 4 lower anteriors followed by immediate implant placement. Based on the CT scan, it seems we will likely need to place a narrow 3.0 implant in the central incisor area with 4.0 or 3.5 implants planned for the canines. Since this is immediate implant placement case following extraction, a gap within socket is anticipated, so GPR was planned using A-Oss Collagen, especially because there is buccal wall defect. The patient was hesitant to have tooth 45 treated simultaneously due to anxiety, so the plan was to address it separately with immediate implant placement. Looking at CT of tooth number 43, here we see a bridge abutment, and the root is deeply embedded, suggesting that immediate implant placement should be possible. Looking at number 41, both the central incisors show significant alveolar bone loss, and the gums have receded considerably. In 41, the buccal wall is mostly resorbed, with the apex of the tooth barely retained. A similar condition is observed in number 31. We planned the surgery after reviewing the CT, deciding between number 41 and 31 for implant placement. Looking at CT of tooth number 33, we see something unusual. The root is split into 2, suggesting a potential transposition with the adjacent premolar in number 34. Number 34 is single root tooth. Number 34 and 33, I think there is transposition. There's a bridge prosthesis and it looks like canine, but number 33 looks to be premolar. On the buccal root, the buccal wall is completely resorbed. After implant placement, bone graft would be imperative. Here, initially 4.0 millimeter was considered, but because of lack of buccal wall, 3.5 was planned. For tooth number 45, although the surgery will be performed later, the current crown fracture leaves only the root rest. The plan was to extract the root and place an implant immediately with bone graft. This is the surgical report. Following placing implants in number 33 and 43 to avoid a 6-unit bridge, while also planning for number 31 and 41 based on the condition of the remaining bone. For 31, because it's a premolar, it would be difficult to place a 4.0 because of buccal wall defect. 3.0 was planned, and hence a 3.5 diameter implant was planned. Rather than number 41, the implant was to be placed in number 31. For number 31, TS3 narrow implant was planned, and because of buccal defect in number 33, 3.5 by 10 millimeter was planned in number 43. Because canine was comparatively favorable, 4.0 by 10 was planned. For number 45, the plan was to do surgery separately, but guide would be fabricated ahead. 4.5 by 10 millimeter immediate implant placement was planned. 3 implants will be placed as shown along with bone graft. This is immediate post-op image. 3 implants were placed in lower anterior region with bone graft. In number 43, implant was placed and 4.5 by 10 millimeter TS3 implant was placed. ISQ was 75 and 78, and within the extraction socket, there was bone graft done. For tooth number 31, it's nothing noticeable, but buccal wall was thin. Additional A-Oss collagen bone graft was done. At number 33, there was a tooth transposed. 4.0 was considered, by 3.5 was placed, and substantial bone grafting was performed using A-Oss collagen. The ISQ value is comparatively low here, with not so favorable primary stability. In 45, immediate implant placement was planned, and this is after surgery. 4.5 by 10 millimeter implant was placed, and the bone grafting was done in the gap using A-Oss. In number 43, after surgery, it's been 1 month and a half. The bone is nicely maintained despite being only 1 month and a half left. And there's bone. 3.5 was placed and significant amount of bone graft was done. Number 31, the ridge was tight, but bone graft was done. In number 45, it's been 1 month and a half. 3 months have passed since implant placement in the lower anterior. ISQ was measured. Temporary provisionals were provided. This is after final prosthesis. Number 31, 33, 43. 4 months have passed since implant placement. In number 45, it was about 2.5 months since implant placement, and final prosthesis were delivered. This was in May 2024. So more than 10 months have elapsed since 31, 33, and 43 were placed, and it's been about 9 months since the implant placement in number 45. In 43, after 10 months, you can see on the labial side, bone is nicely maintained. And on number 33, you can see on the buccal side, previously significant A-Oss collagen bone graft was done, and labial bone is nicely maintained. And in number 31, bone is thin, but it's okay. In number 45, it's been about 9 months on CT since surgery, and buccal wall is nicely maintained as well. Today's case, what is noticeable is that immediate implant placement was done in the lower anterior region. In number 33, there was a transposition. Labial wall was completely resorbed. The root was 2, so A-Oss collagen was used for sufficient bone graft to regenerate labial wall. In the surgical clip, when surgery was done in the lower anterior zone, students from the dental university came on an excursion, so I was providing explanation to them, and you'll be able to listen in. Let's look at the clip. There is a 6-unit bridge between canine and canine. Immediate implant placement will be done after removal. There's root rest in number 5. This is going to be addressed next time. I prefer perio steel elevator number 9. Bridge is connected. When you do extraction, what is most important is to get the fulcrum. So bridge is divided in the center. On CT, there's two roots. This is canine and this is premolar actually. The shape of the tooth is quite unique. This is buccal. This is not canine but premolar, so transposition occurred. The shape was adjusted so that it looks like a canine, so it's quite a special case. The root is long. Canines have long root. Done. Because it's not a canine. The root is divided into two. The buccal wall is completely resorbed on the apex, so you can see the instrument sticking out. For immediate implant placement, you need to remove granulation tissue for sure. What you need to focus is here. It needs to fit perfectly. Over here and here. By having a nice fit, we can be rest assured that the guide went in. For 43, 4.0 by 10 millimeters, and for 33, 3.5 by 10 millimeters. And for this, MS implant 3.0 by 10 millimeter will be placed. Because it's all extraction socket, there's no need for tissue punch or flattening drill. Because here it's a canine area, path drill will be used. For path drill, we need to start with shorter one. This is 7 millimeter drill. Because it's extraction socket, it's not going to come in contact, probably. Because of the handpiece, it does not go in fully. Because it is extraction socket, 7 millimeter is going to be done first. .5 by 7 millimeter was done. Now it's 3.5 by 10 millimeter. .4 by 10 millimeters, so this is final drill. I think there's a slight interference, so I'm going to drill up to 11 millimeters and then place a 10 millimeter implant. .0 by 10 millimeter. The implant is placed to 70 to 80%. It's over 30 newtons. When you take a look, you need to find the height over here. This is adjusted up to the yellow. The depth and path is adjusted. So I'm going to put this in and then move on to the next side. In order to prevent slipping, I'm going to start with K9. If you utilize this in the place where implant is placed, it's better.
아프세요? 지금도 아프세요? 네, 다 됐습니다. 요거까지는 괜찮으시죠?
3.48 by 10 millimeter.
다 됐습니다. 요건 괜찮으세요? 예.
Now implant is going in.
다 했습니다. 조금 아프세요? 예. 거의 다 했습니다.
It's over 30 newtons.
아유, 고생하셨습니다. 됐고, 그냥 꽂아놓고 합시다. 됐고, 그 다음에. 괜찮으세요? 네.
A 2.0 path drill. If you do it up to the end, it's 13 millimeters. Up to the black, it is 11.5. This is 10. Between 10 and 11.5. This is 10 millimeter. If you do it up until here, it is 11.5. We're almost done. It's over 30 newtons.
아유, 고생하셨습니다.
Implants are now placed. Because it's an immediate implant placement case, I place the implant slightly deeper.
고생하셨습니다. 다 끝났어요. 그다음에 둘 다 미니시.
So on here, because there were two roots, I'm going to do bone graft on the buccal side. Thread is not exposed. A-Oss collagen is bovine bone. Collagen 10% and bone is 90%. The particle is going to be placed. I'm going to cover using hidden X method. You do not need to use a collagen membrane on top of a collagenated bone graft material. Healing occurs very quickly. In this case, you can just use a figure of 8 but to really support the graft material. In the case of number 45, the crown was fractured and there was only root left. In this case, because of tooth decay, it is difficult to get to fulcrum. In this case, as shown in the video, I use a number of 1 mold elevator is used. If you can get to fulcrum, compared with the general elevator, you can do extraction more easily. I use it frequently. Root to rest was extracted in this way. Extraction was complete because immediate implant placement was planned. The curettage was done thoroughly. OneGuide template adaptation. As for lower anterior, healing was done. So adaptation was done after prep because this was extraction socket. OneGuide path drill 7mm was used. 2-point contact was utilized. So that there's more stability. In the case of extraction socket, the 7mm, you may not come in contact. And now it's a 13mm path drill. The plan was to place a 10mm implant, so you could do drilling up to this point to prevent any slipping. 3.5 by 10mm drilling was done. When placing an extraction socket, there can be slipping. Next is 4.5 by 10mm OneGuide drill. TS3 4.5 by 10mm implant was placed. Implant was positioned with irrigation. It was placed about 70–80%. After that, hand wrench and implant driver was used to place the implant in its final position. The initial torque was about 30 newtons. It's not really visible, but it's in line with the yellow. Hex positioning and depth control was done. Smart peg was used to measure ISQ value. $79.81 comparatively it's favorable considering its extraction socket. Healing abutment connection was done. Healing abutment connection was done on the buccal side. In the buccal side, gap bone filling was attempted. If you use a healing abutment, grafting can be difficult. In this case, healing abutment was removed and cover screw was used so that the bone graft does not go towards the implant. And on the buccal side, sufficient bone graft was done. In the buccal gap, If there's healing abutment because of contour, bone grafting can become difficult. Cover screw was removed, and in order to prevent graft material going in, healing abutment was connected. You can see that the extraction socket was full. A suture was barely necessary, but suture was done once. Just like suturing extraction socket, a figure of 8 suture was used so that the graft material does not come out too much. Today's surgery was about immediate implant placement. What was noticeable is that in number 33, the root was 2. It's not an unusual case. There was transposition with premolar. I decided to reduce the implant diameter, and in the buccal defect area, A-Oss collagen was used. Without the use of collagen membrane in an area with a buccal wall defect, immediate implant placement was done using A-Oss collagen. And about 10 months later, if you look at the CT follow-up, the labial wall was nicely maintained. Thank you for watching.
시청해주셔서 감사합니다.